After the conclusion of this panel, I'd like to remind everyone we will have a special closing performance from performer Reilly. So please remain in your seats after the panel discussion, and we will get you on your way. With that, I would like to welcome my dear friend and our moderator, Alana Jochum, to the stage. Alana.
Thank you so much, Joseph. And can we just pause for a second and applaud Joseph and the entire Ohio State Bar Foundation for this incredible day. I don't know about you, but I am so energized by what I'm hearing, and I am so excited for this panel that we're about to move into, the intersections of healthcare and legal policy, where we get to talk about the intersections between healthcare, legal policy, and practice. So how many here in this audience are litigators or attorneys that work in courts? Okay. You know, when we don't know something as a litigator, what do? We get an expert. And you are so fortunate to be in this room with these esteemed experts in their field who will be able to provide the knowledge about some of these policies that we are hearing so much about today. So please join me in welcoming Adam Reilly, Manager of Education, Outreach, and Testing at Caracole. Julia M. Applegate, the Director of Equitas Health Institute. And Dr. Scott Leibowitz, Medical Director of Behavioral Health at Nationwide Children's Hospital Thrive Program. So to frame a little bit the panel that we're going to hear from today, you've heard these referenced throughout the day, so I just want to center this, that we do have some proposed policies here in Ohio and others that have actually become law across the country. One of the key policies that we have heard about and is making its way in states across the nation are laws to try to criminalize, and I want to say that word, criminalize, gender-affirming healthcare. So I think it's important for us as litigators, in any case we're prepping for, we would seek the experts of what are we actually talking about here. So I want to start there. What does the term gender-affirming care mean? And could you give us a general overview of what options are available for individuals seeking gender-affirming care or transition-related care? And I'm going to start with Dr. Leibowitz, if you could jump in on that.
Yes, thank you, everybody. I wanted to first thank everybody at the Ohio Bar Foundation, Ohio State Bar Foundation, for including me in this important day. I should start also by saying it's rare that I have a room full of attorneys, and so if I may selfishly just solicit representation for a potential felony that I may or may not commit, depending on certain litigation that may or may not pass. Thank you very much. Okay, so moving on. I would like to say that gender-affirming care is actually care that all of us should receive. Every human should receive gender-affirming care. And when it comes to youth, to start, it's important to note that when adolescents go through puberty, what that does is it changes their physical beings into a type of body that allows them to live in accordance with their gender. And all people, all of us, have the optimal capacity to have the best social, emotional, intellectual development when we go through a puberty that matches what our mind is in terms of our gender. And I think that we often think of gender-affirming care only for people whose genders identities might differ from their physical body. But if we move away from that and realize that puberty is something, and having the right to have a body that matches what our identities are, that's something that we all deserve. And so sometimes when our body doesn't produce the hormones or doesn't produce the effects that we need it to match our mind, we need to seek a prescription, or we need to seek care from a doctor. And there's an evidence base out there that's been decades long that demonstrates that health care for people who need to align their minds and their bodies is something that leads to the best optimal emotional and social and psychological outcomes that they have. And so gender-affirming care on a more broad level respects all individuals' right to assert the gender that most consistently they experience in their minds. And there's many systems issues that can be in place for gender-affirming care, namely the right use of a pronoun, the right use of a name, as you heard in the earlier panel. Also anything from just being supported through, in questionnaires, in surveys, on the phone, not having assumptions made when someone introduces themselves to someone, not being gendered in a particular way on a phone call. Anywhere also from asserting one's identity through social means, through transition in a social way, whether that be using their name and their pronoun in certain situations. For kids, that could be in school, that could be in faith-based institutions, that could be in their families. For other people, it might mean that they need a medical treatment, and for kids, the medical treatment depends on the stage in puberty that they're at, and for adults, mostly who are beyond that, it might mean hormonal care, it might mean surgical care, and overall, just it's an individualized process that is between the physician and the person, and in the case of adolescents, it's between the family and the physician, or the multidisciplinary team. And so that is gender-affirming care in a nutshell.
Amazing, Dr. Scott. I want to give a follow-up question to that. Those who would maybe be advancing some of these laws to prohibit gender-affirming care often say, well, it's in the best interest of the children to stop what you just described as gender-affirming care. And they're trying to protect minors. What would you say are the protections in place for minors seeking gender-affirming care?
Protections are in place because this is a decision that, again, falls between the doctor and the family. And so when a young person enters the office and says, I need gender-affirming care, this is a collaborative team decision after going through a gender-affirming assessment, one where we understand the totality of their issues, we understand the totality of their mental health issues, we are looking for the relationship between their mental health issues and their gender. Gender-affirming care also means gender-literate care, and gender-literate care, the way I would define that, is when a healthcare system is able to understand when gender isn't the issue. Oftentimes, healthcare providers may assume that gender is an issue when it's not, and so both gender-affirming and gender-literate care exist to help really adequately and proactively meet the needs of the young people where they're at. And so this is not just a walk-in-the-door vending machine full of hormones. Families have to go through a lot. They often have to establish care with multiple clinics or multiple disciplines. You often have to wait on a long wait list. There's a time that they have to, sit with the team to help understand what their experience is. There's so many barriers that are in place for families that shouldn't be, but are. So the notion that families just walk in the door, children dictate what they need immediately, and that hormones kind of come from outer space, to families and to kids, or that they're sent off to surgical treatments immediately is ludicrous. And I think that. Again, we're here to provide ethical care within the framework that we provide decisions for all medical issues. And I would say that there's no reason to have to protect kids from their doctors, because if we're providing care that is based on evidence, and it's based on a collaborative, affirmative decision that is made, with a multidisciplinary team and families and parents.
Thanks so much, Dr. Scott. I want to turn to you, Julia, for a minute. What role does Equitas Health play in providing gender-affirming care to the community? And how do you work with other partners, especially trans-led organizations, in this space?
Well, first of all, I also want to take a moment to just say I'm grateful to be here and honored to have this opportunity. I use she pronouns, and So I work at Equitas Health in the Education and Research Department. We have medical clinics in 4 locations around Ohio, and part of what we do is provide gender-affirming care. We also take care of people living with HIV, which sometimes involves gender-affirming care as well, and sometimes doesn't. But our role in this space, when we are taking care of clients who come to us to seek that gender-affirming care, is to meet their primary care medical needs. And so sometimes that involves, as Scott said, really like long conversations about specific treatments to address their gender affirmation. So conversations about hormones, conversations about the need or not for mental health support. It also sometimes involves just a conversation about dental care. How are you're here for my services in a gender-affirming care environment, but we're a primary care medical provider, and you also have teeth. So let's make sure you're taking care of that as well. I think that's an important thing to note, that gender-affirming care isn't just hormones and transition or not. It's care, it's medical care. Social service care, it's sometimes how our coffee is served to us, treatment that is affirming who we are as individuals. So at Equitas Health, our role really is to be a gateway to good health for people seeking a welcoming medical care home, and gender-affirming care while you're in that space is part of our mission and vision, and we do that in lots of different ways. We make sure that our intake forms are inclusive of the pronouns that we talked about earlier this morning, that there's a space for you to self-identify what pronouns you use, including a space that recognizes neo-pronouns. We have our front desk staff trained in ways to ask questions that are gender expansive, so that it isn't simply if you come in and you appear as male, who's your wife? Who's your partner? We ask open-ended questions. When we can't take care of the needs of our clients, those specifically clients who are seeking gender-affirming care, because we are a primary care medical provider, and primary care is something that we should all be taking care of in an ongoing way, right? Like, you think about us, we hope people will think of primary care providers as that, got to make my annual visit, maybe twice a year for my dental care. If it's for my mental health services, it's in that ongoing way. But there are certainly healthcare needs that people who need gender-affirming care need that we can't take care of. So we do work with partners that we have built relationships with, where we can do warm handoffs to get those people the care they need in a gender-affirming way. And so that may have nothing to do with their gender identity in terms of treatment of gender dysphoria. But, recently my appendix got mad, and it's not supposed to do that when you're 50, but it did, and so I had to go, get some surgery. Equitas Health can't help me in that situation, but if there is a referral situation and I need to go see a gastroenterologist or something like that, then we've built relationships with providers that we know, because they've shared that information with us, that they're culturally sensitive. And so we work really hard to make sure that our patients, whether they're coming into us from just having left the care of Nationwide Children's Hospital or similar around the state, or if they've been with us and we need to send them out to someone else to get something else taken care of, that they don't have to face anxiety about their gender identity in that medical scenario, where that's where the warm handoff comes in. So if we don't have a relationship with gastroenterologists or, you name it, then our clients will carry with them anxiety, not about their health condition, but about how will they make it off of the phone when they're trying to schedule that appointment. Hey, I'm a trans woman and I need to get go get a prostate exam. How am I going to make that phone call? Well, we know some prostate cancer providers, and we'll say, call these people, because these people you can make the phone call with, and then you can go to the front desk and you're not going to have to feel afraid. And then when you're actually getting medical care, you'll also be okay. But it's all those preceding steps that also matter. So, I mean, those are some examples. Of course, we do policy work as well with organizations like Trans Ohio and Octopus and others. That's what came to mind first.
I love that, and I think that that explanation shows that gender-affirming care is a much more holistic and broad treatment of the whole human, and I appreciate the various levels that Equitas Health has for that. You know, it goes back to another question that I have. Treatment options varying between minors and adults. Dr. Scott, can you maybe address a little bit of that from the Thrive program, which treats minors? What is the difference between gender-affirming care for young people versus adults?
So the first difference is that with minors, one needs guardians and caregiver consent. That is, you know, for any issue. So it naturally applies to this issue as well. And so that means that we approach families in a holistic way. We don't look at just the one person. We're really approaching this as a family. And there's plenty of research to show that when family acceptance, family support is in place, that mental health outcomes are exponentially higher, better. So that's one thing, which means that there's a shared decision-making role that we all embark upon. For younger kids, for kids who are before the age of puberty, so puberty is kind of the defining characteristic of what it is, what options exist. And so for younger kids, really, there's no medical or any surgical treatments involved. Since all kids virtually, when clothed, could be, you know, virtually indistinguishable, it's a matter of affirming a child's gender through social means, social supports. And we commonly use the phrase insistent, consistent, and persistent. So for a child who is insistent, consistent, and persistent, and you may meet parents of transgender children in the room even, and they can tell you that this is something that is pretty clear. As soon as young kids are able to know that there are differences in their bodies, is as soon as they can recognize that the world is a gendered place. And so children, really the goal is to help just affirm them for who they are and support them with the various things that they do, and that what improves their self-esteem is gender-affirming care. So any activity, any toy, anything that is going to help a kid feel good about who they are, that is gender-affirming care. I don't know if any of you saw that there's like a flow chart that says, you know, is this toy a boy toy or a girl toy? And the question is, well, if you can use it, do you use your genitals to use the toy? And then it's like, then it's not a kid toy, right? And if it is, you know, if it isn't, then it's for any gender, okay? And so that's the flow chart that I always think about when it comes to gender-affirming care for children. So as children move into puberty, we look to understand, we help kids develop a sense of communication, ability to communicate what their needs are, what their experiences are. And for kids whose body changes impact their emotional health in a negative way because it diverges from the gender identity that they assert in that moment, and this can be different for different kids because different kids go into puberty at different ages, that's when an option for certain families who choose to do so is puberty suppression. Puberty suppression is not something that is for every family, it's not something for every kid, but it is certainly an option. What puberty suppression does is that it suppresses one's natural endogenous hormones, the hormones that their body would produce, and it allows for a young child not to go through the puberty that would be distressing to them, or by definition, incongruent with their gender identity. And in time, when they get to a place where they're able to conceptualize different implications of treatments that actually might produce changes that are more irreversible in nature, such as hormones, a young person who has the benefit and the option to go on puberty suppression, should they declare their needs at that time early enough, if they go onto puberty suppression and then they go onto hormones later, what that does is it promotes an experience that they can only have to go through one puberty. And any parent in the room will tell you that one puberty is bad enough. You do not need to necessarily go through two. And we certainly embrace the idea that certain people will go through two puberties because not everybody comes to the conclusion or understands themselves or feels comfortable or safe to come out early enough. So for those adolescents who ultimately do come out later, beyond the time when puberty suppression would be optimal in minimizing the need for two puberties, at that point, hormonal considerations and even surgical considerations and certain surgical considerations for young people whose decision-making abilities are determined to be, by the team, that these young people are able to conceptualize various trajectories of their decisions, and should they be able to do so, as we work through this as a family and as a provider team, considering the risk-benefit of either moving forward with a particular treatment or not moving forward with a particular treatment. And it's a complex risk-benefit analysis for every single family. It's a very individualized process and decision. And I know we're not supposed to get political here, and I'm not going to, because what I'm going to tell you is that the families that we see and thrive, hundreds and hundreds, if not thousands, and across the state, are of all different political persuasions. So these legislative efforts actually impact people negatively of all political persuasions. Families across the board are impacted negatively. And so that's why I can wholeheartedly say that the medical care we provide is not political, and we want it out of the political arena. And so as young people get older, certainly once they are no longer minors, then that's when they can make their own decisions without having their parents on board. But we spend a lot of time in multidisciplinary settings working with psychologists, therapists, psychiatrists, myself, endocrinologists, primary care doctors, our social workers, pharmacists. We're all one big team, and there's always going to be a system of checks and balances. And most notably, it's about really putting decision-making into the hands of the parents and the families. And I hope that everyone has the opportunity to meet a parent or a family or a young person who's experiencing this, to understand the power of gender-affirming care and the fact that the care that we're providing is giving young people the opportunity to live the same opportunities that their cisgender peers have.
I just want to pause right there and thank you for explaining that so thoughtfully. And you anticipated the question that I was going to give you from the audience, which was, can you please go a little deeper into puberty blockers? I think that gave us a really good understanding of what they are and how they may fit into holistic care or not, depending on the individual. Mm-hmm. I do want to do one more question in this area before I move on to topics, and that is gender transition treatment covered under conventional insurance plans? Where does insurance fit into this conversation? And that's to both you, Julia, and you, Dr. Scott.
Do you want to go first?
Well, before we get into that, I just want to follow up something around the puberty blockers. And so I will proceed talking about that by just situating myself in this storyline that we're talking about today as someone who's from Appalachia and is also a storyteller. So I'm going to sidetrack us slightly. And also someone who was born in 1970 and did not have access to puberty blockers. And as I'm sitting here listening to Scott talk about this as someone who identifies as a cisgender, no, not cisgender, as a genderqueer woman, gender nonconforming, when I hear Scott talk about puberty blockers and think about my own puberty, all I can think about is like, what a relief it would have been for me to have had somebody to talk to about the distress that I felt as I got closer and closer to puberty. It was a heaviness that is hard to quantify. I mean, I'm looking around at these massive columns, and I'm just imagining them on my back. That's how the closer I got as a tomboy child, through and through, as I got to 13. because I imagine that was the age where it was all going to just, everything was just going to happen, and and it really was distress around my breast that was just terrifying to me. And, you know, things were really different back then. And I spend a lot of time, since I work in this field and as a lesbian woman who's also genderqueer and nonconforming, I have spent a lot of time myself thinking about, if I were born in 1990 or 2000, how would my journey have been different? And you can't answer those questions, but I can tell you with certainty that if I had had the ability to discuss with anyone what it would have meant to just address the dysphoria I felt in my body because of what I thought breasts were going to mean for me. And this is where gender identity, gender expression, gender norms, social constructs, all of this clashes together, because for me, all I thought it meant was, I don't get to climb trees anymore. I have to start wearing makeup. I'm gonna have to do X profession, blah, 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 a million different things. And my mom wanted me to be a girly girl, and so what I got was standing in the kitchen, her looking at as I was developing, oh, your breast buds are coming in, let's see, turn sideways, and imagine the trauma of that, right? So anyway, when we think about like the impact of something like puberty blockers, the mental relief that can come for individuals who are carrying that fear and dysphoria is just, I think, again, look at these columns. Like for me, I think if I could have taken that column off of my back, how different would my whole life trajectory have been? So when we talk about insurance, because we have to have a diagnosis if we want insurance to pay for anything, which is why I'm talking about gender dysphoria. That would have been the diagnosis code I would have had if that code existed in the 1970s or 80s when I was going through puberty. It depends on who your insurance company is. It depends on how they interpret those codes. It depends on whether your providers will utilize those codes, utilize them effectively according to the rules. I'm not in the space of working with clients on that on any given day, but I do know that it's very complicated, and it's something else that adds a tremendous amount of stress to people who are already carrying a lot of stress in their lives because of their own internal experiences of their bodies, which again would not be a stress if our culture was not so oppressive, because left to our own devices, we would have all figured this out on our own, and as cultures have done over centuries of time. So I think that my answer around insurance codes is that for trans, non-binary, anyone who's seeking coverage for these services, it's very important to find somebody who can help you understand what your insurance policy covers and how to navigate that. And there are people who have that special skill. It is a skill. It is not something that you should try to do alone. It is something that keeps physicians and social workers up hours and hours at night because it's so complicated. It shouldn't be. I'll leave it there and let Scott go.
I mean, and thank you, Julia, because I mean I look at the columns and I can imagine the analogy and understand that for a lot of people probably you're thinking about the stress that you were under during those times and how access to these treatments can be so crucial at such a crucial stage in a young person's developmental journey. What I could say with insurance is, since there's such variability with insurance over, which insurance panels cover it, which don't, who you get on the phone when you call in a particular company can make a difference. And having to have that ability to know, okay, this is not a person I'm getting anywhere with, hanging up, trying again, being on hold. Imagine you have 5 kids, you have carpool, you have to run off to go pick this one up, get that one to school, the temper tantrum's happening, and you're on hold, and then you get cut off after you've waited 45 minutes, and then you get a person who's like, we don't do that, and then you call again. This is what families have to go through, and if you know anything about health disparities, you can understand that people that can't do that have differential access to care. And that is a problem. And even myself as a doctor, I am sometimes on hold with insurance companies trying to fight for even a simple prescription for a simple antidepressant that's not covered, and we run into barriers. The nursing teams are life supports often in the care of these families, and it just takes so much extra resources and dedication from administrators in hospitals who can appreciate the barriers that families have to go through to provide funding for the staff that need to do those frontline phone calls with insurance. And then just kind of an element of luck, whether your insurance company will cover that for your own child.
So we've got a lot more to fix.
Maybe just a little bit.
Just a little bit.
Yeah.
I want to switch us now to another topic that is so important to us here, and that is HIV prevention, care, and modernization work. And so amazing progress has been made in the fight against HIV, both here in the United States and around the world. As of 2019, an estimated 1.2 million people in the United States were living with HIV, about 13% of whom do not know they had it. And over 30,000 infections occur in the US every year. And it was reported this year that in England, 49% of diagnoses are now among people identifying as heterosexual, overtaking the rate among gay and bisexual men. So I want to turn the discussion now to you, Adam. Thank you so much for being part of our panel today. Could you talk about some of the disparities among the people newly diagnosed with HIV, including among injection drug users?
Sure. First, thank you for having me. I'm really happy to have this opportunity and to be on this panel with my esteemed colleagues. So there is, as you mentioned, HIV we've come so far with over the past several years. Maybe not everybody knows, but we have things like PrEP, which is a preventative medication that you take that prevents an HIV infection. There's this whole concept that was mentioned in the last panel of undetectable equals untransmittable. But yet we still see, as mentioned, over 30,000 new cases a year. And through my years working in HIV, I have seen that it's such a dynamic virus because it interacts with all of society. There's all of these different intersections with HIV. It doesn't just impact one person, it impacts their community. It impacts their gender, their identities, their orientations. And it also is kind of geographically different as well. As mentioned in the UK, they're seeing a higher rate among heterosexuals. We aren't currently seeing that in the United States, although maybe we will at some point, especially with COVID. We've seen that the UK is kind of a wave ahead of us, and then we see that later, so maybe that's something we'll see down the line. But what I've seen over the years is, like I said, it's different depending on where you are. And speaking of people who are injecting drugs or people who are using drugs, that's kind of where I got my start in the HIV world. I had a brother who injected drugs, died of an overdose, and we tried to get him, services that didn't exist. And when I did research, I was like, oh, you have to go to like Chicago to get these kind of services. And then I realized that in Ohio at the time, we only had one syringe, or at the time, a syringe exchange program, and it was in Cleveland. And the reason they had that was because they saw in the 90s, that's where they were seeing a lot of their cases. Other parts of Ohio weren't seeing that. And I'm in the Cincinnati area. We didn't start to see that until, around 2010, a little bit before that is when we started to see that problem really take off. And that's what got me to recognize, like, wow, it's different depending on where you are, so you need very unique strategies to address it, not only for the individuals and communities that are impacted, but where they are. Cleveland, Columbus, and Cincinnati, even though they're very close to each other, they're quite different cities, and they have different experiences with HIV, just like an individual has a different experience with HIV than maybe another person might. So that's a big thing that we're seeing in our area. We're seeing active clusters of HIV, of new infection in the greater Cincinnati area, especially in Butler County, which is the county just north of Cincinnati. And luckily, we're not seeing clusters within Hamilton County anymore, although we did see them for a while, and now we're not, but we have robust syringe service programs that have really helped to tamp that down. But we still are seeing our rates rise. So they're rising in other communities. So what we're seeing a lot of is younger African American, Black, people of color, men of color who are having sex with other men or might identify as bisexual or gay. We do see a lot of that. And we're seeing an awful lot of transgender women, especially transgender women of color, contracting HIV, which, as stated by another earlier panel, that group of people experiences violence at an exponential rate higher than any other category. And so to have HIV on top of that, to have the gender discrimination on top of it, and then you have racism on top of it, that community is dealing with a lot. So many may not know, but when it comes to HIV, I mentioned we have PrEP, we have all these things. I always say that we have all of the tools that are needed to end HIV in the United States and really around the world. We just need to put some effort behind it and get legislators behind it and get people to understand that, yes, we can get there and get around some of the problems. But in Ohio and in 32 other states, we're never going to see that happen if we don't decriminalize HIV. I mean, it is a crime to be living with HIV, whether you contracted it from using drugs or some sexual act, or you were born with it. If you're born with it, you're born a criminal, basically. And that's a huge barrier. That also leads to the stigma. And the stigma, those are the two things, the criminalization and the stigma, that is stopping us from being able to stop HIV. And we have a goal in Ohio and in about 50 different jurisdictions around the country that have been identified by the federal government as, for lack of a better word, like hotspots for HIV that account for a huge proportion of our new infections every year. In Ohio, it's Hamilton County, Franklin County, and Cuyahoga County are all three what they call ending the HIV epidemic jurisdictions. All of those counties did plans, that they had to submit to the CDC and HRSA. This is a federal level thing. All of those counties also put in their plans to destigmatize HIV, strategies to try to destigmatize it in the community, one of those being decriminalizing HIV. And I'm gonna call all three of those counties out right now because they put it in a plan that they submitted to the federal government, but they won't sign on to a letter to try to get the state legislator to do something about it. So they'll submit it in some grant proposal to get millions of dollars, but they're not doing anything at the moment to really put it into action. And I can't do my job, and the team that I supervise cannot do their job of going out into the community, meeting people where they are, providing them with gender-affirming services, orientation-affirming services, and just accepting of whoever you are, whatever you're doing. We want to get you tested. If you're negative, let's get you on PrEP. If you're reactive for it, if you're living with HIV, let's get you the treatment you need. We will support you through that. If you need case management, help with pharmaceuticals, if you need help with housing, we will work to get you undetectable. You do all of this work, the individual living with HIV. You're the one that has to take the pill every day. You're the one that has to put up with the bullshit, that people throw at you just because of some infection that you have. I don't see people harassing somebody with diabetes at an all-you-can-eat buffet, just as an example. But that happens to people living with HIV on a day-to-day basis. So places like Equitas, like Caracole, where I am from, we can't reach our mission without this external help from the legislator. It's a real barrier. Sorry, I'm going on and on, but it's a real barrier, and it's really disheartening. I mean, I have a lot of hope that it would happen. Trying to start a syringe exchange in Cincinnati, Ohio in 2005 was like, good luck, buddy. But it opened, and Now we have them statewide, and getting it done in that part of the state was a big way to get that done. And now that county has 8 different programs, and they're widely accepted, and they're accepted in other things too. I think we need to do the same thing when it comes to the stigma and the criminalization around HIV, and it really needs to be called out, and it needs to be called out by everybody, whether you're living with HIV or not. If you don't know anybody with HIV, well, you do. They just haven't felt comfortable enough to tell you that. So we all have people in our families, in our networks, at work, houses of worship, whatever our community is, that are impacted by this, and it's completely unjust. And if we can't stop HIV by 2030, which is the goal is to get the rate of HIV down by 90% by 2030. So in a county like Hamilton County, if we did that by 2030, we would experience about 18 cases of HIV a year. And what a huge reduction. And I think what a gift that we could give the next generations. Because as you said, I was born in the early 80s. When I came out, one of the very first things that was said to me, and said to me many times, was that I was going to die of AIDS. And that was terrifying, especially in the mid-90s. I saw the news. It was terrifying. And to be able to not only have this, when I look at the things that we do and how we talk about HIV now and some of our marketing materials, and then you look back at what the CDC was putting out in the mid-90s, it was all fear-based. Now everything we're doing is very empowering, and there's no fear around it. It's just get on PrEP. If not, then get undetectable. It's going to be great, which is totally true, but why do we want to put people through that when we don't have to? We have a real opportunity to eradicate something here that has such a disproportionate impact on communities and individuals that are already disproportionately impacted by a million things. And I can say for myself personally, for my friends, for my community, that if you just took one thing off the table, it would feel like a column coming off, because it feels like there is so much there. So thank you.
Thank you so much, Adam. And I want to dive into the criminalization in just a minute, but I want to take a step back because I'm looking at our audience and I'm making some assumptions, but I think that many of us in this audience had a very different learning of what HIV was and contracting it, and have a different educational foundation about what it means to be a person living with HIV or AIDS. I want to take 2 things that you said and just if you can give sort of a quick overview over each of them. You said U equals U. What does that concept mean for someone who may not have grown up learning about U equals U?
Sure. So U equals U is undetectable equals untransmittable, or another way to refer to it could be virally suppressed. But it basically means that the virus is suppressed to such a level that it's not present in any fluids that would cause transmission. So if I'm living with HIV and I'm undetectable, this is also where the criminalization comes into how dumb it is. But if I'm living with HIV and I'm undetectable, whether I'm sharing drug use equipment, whether I'm having unprotected sex, whatever activity I'm engaging in, I'm not putting that other person at risk because I can't transmit my HIV to them. So there's no risk there for people. Which is a complete game changer. It's a really empowering thing for people living with HIV to feel that. I know a lot of people with HIV, they have in the back of their mind that they're not, they don't want to pass it on to someone, even though there's this whole, urban myth kind of thing that, there are people out there trying to intentionally do it. There's not. That's not a thing. But it takes away a lot of stress. And you don't have to completely worry about have I exposed my partner this time? So that is, the mental health piece of it is huge. And it's just, I've been in this field and stuff for a long time now. And I would say when I first started working in it, it didn't look like a cure was possible. It didn't look like PrEP would ever be a thing. It didn't look like undetectable equals untransmittable would ever be a thing. The amount of progress and change that has happened in the past several years is amazing. And as a general public or as a community, we need to take the lead that researchers and doctors and scientists have shown us over this time that all of these things work, and now we need to put it into action on a large scale.
So I want to stay there for just one more minute because you went exactly where I was hoping you would, which is PrEP. Again, this is a term that may be very new to some folks in this audience. What is PrEP, and can you discuss some of the recent news about several people being cured of HIV?
Sure. So PrEP is pre-exposure prophylaxis, and it's basically a pill, and there's now an injectable form that you would take on a daily basis. It's also a drug that's used to treat HIV, but if somebody is not currently living with HIV, but they take this drug, it protects the cells that HIV tries to infect. So if I'm on PrEP, HIV gets into my body, HIV can't multiply and go through its life cycle because it can't access my CD4 cell is the cell that HIV likes. And then it just dies. And then the body will get rid of it through, waste or tears or something like that. There are PrEP assistance programs all over the state of Ohio. So if people can't afford it, there are ways to get that access to PrEP. It's birth control for HIV. There you go.
What a great way to think about that. That's a really great shorthand to have.
And then as far as the cures, there's some really exciting things going on. They've been very small scale. But it seems like, in HIV, when you look back over the years, that's how it starts out. It's like this really small scale thing, and you hear about this one person somewhere in Berlin or London who's been cured of it or something has happened. And then years later, you're like, oh, well, this one thing led to this entire new class of medications. And it seems like we are moving further and further and closer to a cure. I don't want to sound too optimistic, but it really does. And it's very exciting.
I think optimism is good. I think we need a little optimism right now, right?
We do.
We're hearing the science move. We're hearing some hope at the end of this. And yet you've referenced this idea of criminalization. And just as a little bit of background, Ohio has 6 laws that criminalize people living with HIV or AIDS. Essentially status offenses. Can you tell us a little bit more about that and the Ohio healthcare modernization movement, of which Equitas and Caracole and Equality Ohio are a part?
Yes, I can. So first, there's a statewide group which is made up of individuals and interested organizations like Equitas and Caracole and Equality Ohio that is working to update those laws. Let's be honest, we know where we are and what legislature we're in. We're not going to get these laws repealed. So, although in my mind, that's what needs to happen. But working within the reality that we are living within, we are working to modernize those laws. And when I first learned about these, it blew my mind. I'm not a lawyer like many of you are, but at least from what I understood, you have to commit a crime to be charged with a crime, and there has to be some kind of damage done or harm of some kind. At least that was my understanding of criminal law. And that's not how these laws work. It's all about the disclosure. So did you disclose your HIV status? Well, if you didn't, then you've committed a felony. But then they don't ask, well, did the person that you didn't disclose to, did they contract HIV? Or did you take mitigating steps to mitigate their risk? Did you use condoms? Did you engage in sexual acts that aren't going to transmit HIV? Are you undetectable? It doesn't require you, none of that matters. It just matters if you disclosed. So that's one aspect of them. And then there's upcharges, So if the one that seems to be most widely used in the state of Ohio is the Harassment with Bodily Fluids Law, which is usually in a correctional facility. So it's somebody that throws, some kind of bodily fluid at a CO. That's gross, and that's already a crime, no matter your status. But if you're HIV positive, not only is it a crime, but then you get a penalty enhancement for that. Solicitation is another one. That's a crime. But if you're living with HIV, you get an enhancement with that. Then there's these other things on the back end, like we are just screwing people in so many ways with HIV that, I could get charged with these and somebody, it could be a revenge thing, or a lot of women are at a really high risk of this as well with domestic violence situations, where they could say, if you leave me, I'm just gonna go and tell them you never told me you have HIV. And then I'm gonna take you to court, and who knows how many charges you get, who knows how many you get convicted on. If you do get convicted on them, once you get out, you may have to register as a sex offender. And I don't know if anybody's had the experience of getting one of those little postcards in the mail saying you have a sex offender living in your neighborhood. It's got your picture on it, it's got the address of where you live, and it also has your crime on there too. So if your crime was HIV related, you've just outed this person's status to their entire neighborhood. Another thing I don't quite understand is how the judicial system gets around HIPAA, but I guess it doesn't apply to them. So that's kind of it. It criminalizes so many different aspects of life, and then adds all of these different barriers onto people as well, especially that sex offender barrier. I mean, when I think of a sex offender, I think of somebody who's committed a sexual assault, or they're a pedophile, something like that. I don't think of somebody who maybe had HIV, didn't tell their partner, but they had consensual sex and there was no transmission that occurred. But all of a sudden now they're a sex offender and they are told where they can't live, where they can't, like it's really hard to find where you're gonna work, where you're gonna live.
That's
yeah,
right.
Sorry.
You're talking about some of the barriers that criminalization, that looming threat of criminalization simply for existing as a person living with can create. And certainly that would probably not encourage a person who is unsure about their status to get tested and then know their status and then get into care that I'm hearing from your description can actually be so life-saving, has grown leaps and bounds in terms of the science, and really be working towards eradicating HIV completely, ending the epidemic as our counties have committed to. So we've talked about gender-affirming care. We've talked about ending the epidemic of HIV. I want to turn to a couple more health issues in the time that we have remaining. I'm going to go back to something that was brought up earlier in our panels today. In the 2021 budget, Ohio enacted a provision allowing healthcare workers, hospitals, and health insurance companies to refuse to provide or pay for medical services on the basis of, quote, moral, ethical, or religious objection. It's very broad, especially when you have the word moral in there. Can you each tell us, and I'm going to start with you, Julia, how might this affect LGBTQ individuals seeking medical care, whether specific to gender-affirming care, HIV treatment, or any other health care that you can think of?
Well, it's pretty easy. You go get your medical care and your doctor says no. And they don't have to explain why. They don't get in trouble. You can't get the care that you need and you're left without your care. And what can that look like? It can look like a trans man who has been, transitioned physically, socially for 10 years, but still has a uterus and has, a sudden problem with their uterus. I have a friend that this happened to, and he went to an urgent care bleeding, and this was before the medical conscience law. Because this is, let's face it, been going on for decades, that people could do this. It just wasn't legal, but now it's formally legal thanks to people who sit in these chambers. And so he was turned away by the provider and almost died. He needed an emergency hysterectomy. So that's what it looks like. It looks like an organization like ours hiring someone, and unbeknownst to us, this person has a religious or moral objection to serving our patient population and now can be among our providers and be actively anti-trans and be within their right to do that. And now we have an employee who doesn't want to take care of our community and by law is perfectly, welcome to do that. And we have to contend with that employee and what that means for our years. And we're in our infancy as an agency. It's 2022. We opened our doors in this capacity in 2016, 6 years of building trust with the trans community that we are a safe place, and now we are at risk of damaging that relationship because we now have an employee who's completely within their right to do this. It can manifest in all kinds of ways, but I would say that this law will result in people dying, and that is not an exaggeration.
Dr. Scott?
Yeah, I would say it's not just about that trans man not getting an emergency hysterectomy. It's about that trans man not getting treatment for the heart attack that they get coming into the emergency room. So it's both, gender-related care as well as non-gender-related care, just by essence or just by virtue of who that person is and the care they've received. That would enable them to not get the care in all facets that they need. It's also about young people going to a doctor and hearing the idea that, this aspect of you is something that the doctor's not comfortable with, you have to go see someone else. Mm-hmm. That is against the core ethics of what we take our Hippocratic oath to uphold. That is something that promotes shame. It promotes a sense of being othered, being wrong. Again, during childhood years, during teenage years, these are crucial times. Of course, I'm speaking to that age group. That's the age group I work with. And then they have to come to a different doctor to get the care, and they internalize these messages of shame throughout the course of their life. It leads them to hide who they are. And that's a theme that you hear throughout everything that we're talking about, whether it be gender-affirming care, whether it be sexual orientation, whether it be HIV. Most of these issues, the issue of HIV is a psychological one more than anything else, because it's about hiding elements that you are feeling are wrong because we live in just a culture and a society that presumes when one has a particular gender identity, it's supposed to match a particular body type, that's supposed to match a particular attraction, that comes with particular sexual behaviors, that comes with a set of what hormones your body is supposed to get, and that obviously that is just not representative of the variation and diversity of the human experience.
I'll add, too, that it's not simply the doctor or whomever in that medical care provision scenario saying, no, I'm not going to take care of you. It's also another barrier for the people who are trans or gender nonconforming, non-binary identified that sits with them before they even have an experience with a medical provider. So it's another thing that you carry in your backpack of weight, the things that the stress and the anxiety that you carry with you, because you then are fearful again. You haven't even had an experience with a provider, but should you need to have an experience with a provider, you now have to worry, well, will they, as they are legally allowed to do, just say no? This is now a thing that if you're a trans person or gender nonconforming, you have to just know this. Before anything happens to you that you might need medical care, you just have to know you can't even be sure anyone's going to treat you. Or they may say to you, well, I can treat one aspect of your medical care. I can, sew up your cut, but I'm not going to give you your hormones. They can pick and choose what they want to do for you, and which again is violates, like Scott's saying, this belief that we as patients carry as well, because we learn that there's an oath that physicians take, that now well, I am wrong. Because the law, they've all just said, this is okay for doctors to do this. Another thing that tells me and reminds me that I'm wrong. And then there we go again with this growing weight that we have to carry around with us.
Every single day, there are families that are sitting with anxiety about something happening to them or their kid and wondering if they're somewhere that might not be in the opportune place. Will this be a place that I could get my needs met? Families are asking doctors like me and my colleagues to write letters that they can carry around in their wallets at all times to say that a medical system supports who they are and that the hormones that they take or the, whatever treatments that they're getting or the pronouns that they use or the gender that they are is medically indicated. And so they want that authority figure like me to validate that so that when they wind up in an emergency setting, they are prepared to be able to almost fight the medical system to get their needs met. And that is what people face every single day, all throughout Ohio, all throughout the United States and the world.
And I'll just add one other thing. Sorry, Adam. Because I think what you're saying is so important. We just heard earlier this afternoon that, House Bill 616 or whatever, it's going to get legislators' votes. Hey, maybe they won't even vote on it. They don't care. They just, put it out there. I can satisfy my constituency that I signed on to it. I'm never going to vote for that. A legislator might think I'm not that cruel. But you are failing as a legislator to stop and think about all of these families every single day, all of these kids every single day, all of these people every single day who are terrified. And it's not just the kids, it's not just the people who are trans, it's the people who love them, it's the people who teach them, support them, drive them to school every day in the school bus. All of those people are terrified. It is terrorism. It is terrorism.
I couldn't agree more. I'm sorry. Obviously, this is something that just is really, really challenging for all of us, just because, I sit face to face with families day after day after day since these efforts are established. And again, people of all political persuasions, where they sit with the fear that their entire lives have been upended. And I sit with families that are moving away from Ohio because they do not want to risk their entire kids' lives, healthcare being removed from them. These are families that are contributing members to society, that participate in the Ohio economy, that are productive members with educational opportunities, creative minds, people that could advance the cause for all of us, people who are here and willing to be servants to the public, and they're being forced out. They're being kicked out of a place that they deserve to be able to live in. And I think that terrorism is not an exaggerating word. It really isn't.
I would agree with everything. But as far as people moving out, those are people that have the resources to do so. So there's plenty of people that don't have the resources to do that. And what their remedy might be is to just not seek medical care until it's an emergency. And if they do that, then what if they show up at an emergency? This is where it leads to like actual deaths. Like, I know a lot of people that already have a hard enough time going to the doctor. They don't feel comfortable with it for whatever reason. You put this on top of it, that might outright stop them from getting regular primary care. And then if they do that and they end up at an ER somewhere, wherever it is in Ohio, it could be at a hospital that you would think, of course I'm going to go there. That's a great hospital. They provide great care. It doesn't matter because they might have an ER doctor that individual is morally objecting to them existing. And I just find that just flat out like, I can't say it on here. But it is, you don't get to object to me existing. That's not how this works. And it is terrorism.
It is cruel, and it is hopefully also illegal. and will be determined so by our courts. I want to just give a quick overview of how this particular medical conscience clause came into place. We're talking about this one as a law. It is a law that has passed here in Ohio, but it didn't go through the normal legislative process. It was jammed into our budget at literally the very, very last minute, before anybody, frankly, even knew about it. Equality Ohio, we found it and said, oh my gosh, what is this piece in here? And then all of us came together as advocates to fight against it and try to get the last conference committee to reject it or the governor to veto it. So it is law. But an update since we last gathered together in talking about this is that the city of Columbus has actually filed suit challenging this provision as unconstitutional in 16 different ways. So we're really grateful for the city of Columbus taking that legal step. And our last panel was talking about the power of the courts and ACLU and Lambda Legal. I know that other cases are being explored here as ways to challenge this. So perhaps, as Judge Mackey said, our courts will be able to be the backstop in this case. I want to shift now to the not laws here in Ohio, but the things that have become laws in other parts of the country. Legislatures in states nationwide are currently discussing health care for children who identify as transgender. You literally just have to turn on the news and say, my gosh, what state today has passed one of these anti-transgender youth bills? Been doing this work for more than 10 years, and 13 states have passed an anti-transgender youth bill in the last 3 or 4 months or so. Ohio has legislation pending here. So to our panelists, what is the current policy in Ohio, and how might providing gender-affirming care change under laws such as the one in Alabama's that was passed in Alabama that would make providing hormone therapy a felony? Dr. Scott, you referenced that at the very beginning. How might all of our discussions today, all of these advancements in medical and scientific health care change if HB 454, which is the version of that here in Ohio, were to move forward legislatively?
I mean, I'm a psychiatrist, so I'm here to help other people with their depression and anxiety, and I can only just, get personal and say, the degree of depression and anxiety that our team and the families that our team helps, that we would face because of the elimination of the services we provide. It would be devastating. Doesn't even really speak the words of what it's like working every day in this climate, and having to do just as much, spend as much time defending the work as we are doing the work. This is a career, that 14 years that I have of experience working with this population. And it's not just me. Our whole team collectively has decades of experience working with this group, and to the fact that we just are, people who have no clue about anything that we do, zero. They've never met any of the families, they don't understand this, and that they're not threatened by others' existence. It's really mind-boggling to me, because we are involved in multi-site grants through the National Institute of Health that would end. We are, these are $1 million grants that are being funded, that we went through hours and hours of writing these grants with our colleagues in Washington, D.C. and in Chicago. We have educational programs, we have group therapy programs, we have ways of delivering care. We have hours and hours of team rounds where we're talking about the ethics behind the care. And that's just our hospital. There's Cincinnati Children's Hospital, there's Dayton Children's, there's Akron Children's, there's Cleveland. Like, the amount of people whose lives would be affected because certain people have either a power or fear-based strategy that is rooted in getting them to walk the halls of this very building is, again, just horrible. It's horrible, and what was said earlier, whether or not this bill passes, the damage is done. The damage is already done. These families are walking around afraid every minute of every day, and I invite every single person in this room to do whatever they need to do to be an ally to lead to the immediate withdrawal of any effort that threatens the youth and families of Ohio.
Dr. Scott, one more follow-up to that piece. There are clinics across the nation like the Thrive program. What are you hearing from your colleagues in some of the states that have passed these measures? What are some of the reactions and frankly, self-preservation steps that are being taken?
Yeah, I mean, one of my very good friends, a pediatric endocrinologist in Dallas, her clinic essentially has ceased providing services. This is not even just like a threat looming. This is an actuality. Kids in Texas don't have the place that they had like a day before that clinic closed down. Kids in Arkansas, kids in Alabama, kids throughout the country, and I can tell you that I heard one of the attorneys say that their client is the Constitution, and I can only imagine that in this setting that the Constitution, so long as I'm a citizen that lives under this Constitution, I couldn't imagine these laws, or these efforts actually being within the parameters of what the Constitution is, because it's unheard of. It's absolutely horrifying for the families and for the providers who have built decades of their careers to help kids and families to have to go through this and turn to their families and say, sorry, I can't provide this care to you anymore in this state. And for those of you who don't have the opportunity to move out, you have to stay here and suffer. And for those who do, well, you have to move if you want to get the care that you need, just to a certain state that happens to be more friendly.
You talked about the harm that is experienced simply by the introduction. And I want to give one example that we know as a trend through Equality Ohio's work with other national organizations. Who here has heard of the Trevor Project? It is a life-saving hotline for our young people who are contemplating self-harm. And we know that there is a parallel spike in calls to the Trevor hotline that directly parallels the introduction of these legislations across the country. So when we see one of these bills be introduced, as we heard earlier on the panel, perhaps for purely political reasons, the direct impact of that is spikes to the Trevor hotline by young people calling because of that fear that they're experiencing.
You don't need the Trevor Project hotline data to say it. I'm proof personally of my own inbox in my own electronic health record of the crises that we're managing every time an effort like this happens. Every hearing that happens, every time something hits the news, it's re-traumatizing all over again every single time. So I don't need that data. I have my own data. Yeah.
Can I add something to that?
Absolutely, Julia.
Because those calls spike, and not all of those kids are saved. And I can tell you that in the work that I do at my organization, which is a lot education focused, that it's been within the last 8 months, we did training with the Franklin County Coroner's Office. And we did that because they saw a spike in trans suicide. And this is again, the very real impact of this kind, not just legislation, but threat of legislation, climate. Children, adults will die. And they will die because they are afraid. And there seems for them to be no way out other than to take their own lives. And so, look at every state has annual suicide reports. Are they reporting gender identity when they report suicide data? Often they are not. But when they are, you will see those numbers climbing. I mean,
And just
That will happen.
I mean, just of note, like here in Columbus, Nationwide Children's Hospital has a world-class facility. It's called the Behavioral Health Pavilion. It's one of a kind. It's the only children's hospital in the United States, and I say this having worked at Boston Children's and Lurie Children's Hospital, Chicago, so I understand the climate of mental health and the services that are provided in different children's hospitals. Well, here at Nationwide Children's, they've bravely made a revenue-losing discipline and service its hallmark feature. And so this multi-million-dollar, like $100 million facility that is a mile away, provides care to all kids, not just transgender kids, obviously. It's across our entire catchment area. And I can tell you that we are understaffed, even with 30 child and adolescent psychiatrists. We have one of the largest departments in the entire nation in a children's hospital. And with that amount of child and adolescent psychiatrists, we still are understaffed and overworked, in a pandemic no less. And a law that bans care that is evidence-based, what that does is that limits recruitment efforts for people to come to world-class facilities like in Ohio, even for non-gender related care, for cisgender kids. All kids are suffering when a ban on a particular group, especially a vulnerable group, is even on the table. No child and adolescent psychiatrist, which there's already a deficit in this country. There's about 8,000, 9,000 child and adolescent psychiatrists in the United States, with a current need for about 21,000 child psychiatrists. So there's a pediatric mental health shortage for all kids. And what these types of efforts against LGBTQ youth do is they then send a message to doctors around the country: don't come to Ohio, because here you have to worry that your care is going to be legislated the next time some issue becomes a hot topic that allows for a power grab. And so I think this is not just an issue for the kids and the parents and the families that I see. This is an issue for all youth across Ohio.
So we're coming to the end of our time together, and I want to just do one quick fact check in terms of this legislation, because I know it can be confusing and hard to remember sort of where things are with that, and that is the medical conscience clause. Yes, that is law. Shameless plug, if anybody here experiences, or if any of your clients as attorneys experience a medical denial, please contact the Equality Ohio Legal Clinic, 855-LGBT-LAW. We are documenting those denials as part of efforts to look at the legalities of this law. But the other pieces are again proposed, and we know that there's harm in that, and that's a bill, Don't Say Gay, Don't Mention Race, is out there, has just been introduced, a bill that would criminalize gender-affirming care, and a bill that would prohibit young people from playing sports. And unlike in other states where it has passed, it has not passed here, and we have a chance perhaps to disrupt that, and I want to make that point very, very clear. In this last bit of our time, Dr. King said the arc of the moral universe is long, but it bends towards justice, and a dear mentor of mine said, yes, if we help bend it. So in that sense, what final thoughts do each of you have? And I forgot to also say the HIV modernization work, no legislation pending yet, but in that optimism, we know that efforts are underway to help try to modernize those 6 laws that are status offenses and criminalize folks. So Hope, can you leave our audience, each of you, with a final thought in these final few minutes that remain? What is one thing you want our audience to take away as a final thought from your perspective as an expert here? Adam, we'll start with you.
Okay. I think one thing that kept coming up all day today, not just this panel, is fear. A lot of these laws that are passed or proposed are based in fear of the other or something that people don't understand. And then these laws cause fear in the people that they impact. So you've got fear on both sides. And fear is not a good thing. So let's end on an optimistic note. I think that I agree with that whole, the arc of history is long but bending, and I think the way you get rid of fear is that you live your authentic self, you do you, and you educate people in those soft ways by living your life and who you are, advocating for yourself, advocating for others, and being out there so that it is made clear that this community is not something that should be feared. That's what I would say. Be out there and don't be afraid of people who are afraid of you, because they're only afraid of you because they have no idea what you're like and what your community is like. And once they do, they won't be afraid anymore.
I am a big believer in everyday activism, and so we all have spheres of influence. They can be small, maybe the two people sitting next to me, or they can be massive, like the whole state of Ohio, or much bigger. But I believe that we each have a responsibility to protect vulnerable people. And there are many vulnerable populations, and they're not a mystery. We know who they are, right? We as white people, historically in this country, have always moved away from the vulnerable people, right? That's why we have exurbs. But we know who the vulnerable people are. It's not a mystery, right? So be an everyday activist. You can put that trans pride sticker on your car and it will make a difference. It's visibility, right? Or you can go much further than that and join Equality Ohio and make those phone calls. You can be the friendly neighbor to the person who has the courage to fly their rainbow pride flag, or put out the sign that says Black Lives Matter. You can say, I agree with you. I'm going to put out a sign too. You know, you can. When you see something going wrong in a grocery store, you see it, like we see people. You can be not a bystander. You can be an upstander. And that is where you will take in your circle of influence, whatever it is, whatever moment of the day that's happening, and make a difference. Because collectively, all of those differences are what causes that arc to bend towards justice. So I don't believe in wasting time. I think that's why I believe in everyday activism. We have an opportunity every single day to make a difference, and it adds up. We've seen it. I've seen it over my lifetime. I'm legally married now. I was 12 years illegally married, and I'm 5 years legally married because of everyday activism that piles together and turns into Lambda Legal and equality and all this stuff, really making the change at the Supreme Court. So that's my kind of message, is be that everyday activist.
Dr. Scott, you?
I would say that two things. I would say that recognizing that these issues around gender, sexuality, gender identity, gender expression, these are issues that we only think about when they differ from what our brains are brainwashed to think is sort of supposed to be. And really, if everyone can take a step back and realize every human has a gender identity, every human has a way of expressing their gender, everyone has a sexual orientation, and we all have a certain body, and they all intersect in different ways, and that these are applicable even for people whose gender identity matches their bodies, so cisgender people, for example, that their emotional health, their psychological health is dependent on gender-affirming care as well, because if you think about it, a lot of depression, a lot of anxiety, a lot of externalizing behaviors from certain people always come from this notion of not being feminine enough or not being masculine enough, and that's for people who are completely comfortable in their bodies. Their minds and their body, they do not have dysphoria, they do not need any treatment, but because the health system doesn't really think about gender for everybody, it only thinks about it when the other walks into the office, we tend to perpetuate this notion that this is something that only matters for the LGBTQ community when it's really applicable to all of us. And so I do think that if we can all do our part to realize and appreciate and understand that your own identities, no matter how aligned with your body or not, impacts your overall psychological, emotional well-being, and support the youth to developing a sense of gender literacy and understanding that gender stereotypes kind of brainwash us and that we need to move away from that and embrace the younger population for teaching us more about different notions of gender instead of like dismissing it. Just embrace it and understand it and sit with it. I think we're all for the better because we live in a place where conversation with people who tend to be afraid and tend to not appreciate or understand another person's experience. Like, I have been personal witness to being able to meet a person where they're at and help them understand how to support their child in a way that they never imagined they could. And then time goes on and their child is supported, affirmed, and they are all the better family for it. So we can all have those conversations and appreciate that.
Adam, Julia, Dr. Scott, I don't think we could have had a better panel to talk about the intersections of healthcare, law, and policy today. Would everyone please join me in thanking you for your time?
Great job. Good job. Go team.